Hello and welcome to this second edition of CREGÉS COVID-19 Interview regarding social issues in aging in the context of this pandemic. We really hope you enjoyed the first one that was in French and will enjoy this second one in English. I am your host, Mélanie Couture, institutional researcher at the Center for Research and Expertise in Social Gerontology, CREGÉS, of the CIUSSS Central Montreal. For this interview, we will talk about a delicate subject, the mistreatment of older adults in long-term care facilities. We will try to understand this phenomenon and how the pandemic has pushed it into the forefront. We will also explore possible solutions to counter mistreatment in this context. For this CREGÉS COVID interview, we have the pleasure of having someone who has been working to counter mistreatment for more than 30 years, Mrs. Sarita Israel. She is the coordinator of the area of expertise to counter mistreatment. I have to say that I've been working in close collaboration with her for the last 8 years. So I'm happy to present to you Sarita Israel.
Hi, Melanie. Thank you for the opportunity to have this interview with you. And yes, in fact, we have been working closely to understand better this problem and come up with some solutions that might make this problem less of a problem in the future.
Yeah. So the first question I'm going to ask you actually is, well, thank you very much for being here. But the first question I'm going to ask you is, actually, recently we've been hearing a lot about mistreatment of residents in long-term care facilities in the context of COVID-19. So I think the first thing to know is, can you just first explain what is considered mistreatment by giving a few examples?
Okay, so I'm going to start by giving you the official definition of mistreatment that we have in the Government Action Plan to Counter Mistreatment and a lot of the official documents. So mistreatment is a single or repeated action or lack of adequate action that occurs in a relationship where there should be, or there's an expectancy of trust, and that it causes harm or distress to an adult, whether it is intentional or not. And basically the beauty of this definition is that it's rather causal and rather objective. What we're looking for is what is the cause, we can come up with a solution. And it's less angled on looking for blame or looking to find, a culprit or a victim. So the point also that I want to bring up, which is kind of important, is the issue of intentionality. I think that it's important to note, and it's reassuring, the majority of mistreatment is not intentional. The average person does not set out to do wrong. And for sure, public institutions and many private institutions, when they're setting up services for older adults, are not thinking of harming them. But by putting in some practices that may not work out or whatever, unintentionally, they harm them anyway, and that must be addressed.
Okay, so intentionality means, it doesn't mean the person wanted to harm the older adults. So you don't have to want to hurt someone to actually mistreat them in a way. So that's good intentions.
That's the importance of naming it, because, and I think that, and I'm going to bring up something else in the definition that actually is quite important, and that maybe will explain why it is so hidden and less talked about. It's that whole issue that it occurs in a relationship where there's an expectancy of trust. Who do we have trust with? Family members, the people that take care of us, whether it's paid caregivers, whether it's a residence that we went to get services from. So we went there because we trusted them. And we may sometimes think that they're doing the right thing, even though the outcome is not so great, for ourselves. And then what happens if I denounce? Is it going to get worse for me? Am I going to lose my relationship? Am I going to lose my services? So it's actually that relationship where there's an expectancy of trust that creates a certain dynamic. And the dependency for something as important as care that creates a certain dynamic. That's the importance of being able to recognize it and to name it so we can do something about it.
And in the context of COVID-19, what actually changed?
It's interesting because when I think of COVID-19, and you might find this a little bit interesting, I find it that it has, brought out a dialogue. So even though it's extremely negative and it's been extremely heart-wrenching to hear what has gone on in our long-term care facilities, On the same token, we have a lot to learn from this this situation. And really and truly, if you look at risk factors for mistreatment in long-term care facilities, it is the perfect storm. It created the perfect storm. So if we look at a risk factor related to individuals in long-term care, the first and important risk factor is not to have visits from the exterior. Now, we had to make some choices here. For, to be able to control the sanitary crisis, we stopped individuals from going in. So who did we stop? We stopped the family member, which is actually the one person that brings a type of care that is not related to physical care. Sometimes, yes, but it's that emotional care, that reassurance, that advocacy that the person loses. So A, not having access to loved ones that could look out for our well-being. So that was number one. Another very important risk factor is the capacity of the individuals that give the care to do the task. Are they trained for it? Are they capable to respond to it? What happened with COVID-19? You had people that were at a certain level of care that all of a sudden went to an extremely different level of care, and people were not ready for it. Aside from which then, already we had a lot more people being depleted and needing more time to receive the care that they needed at a time where the people that worked there had to start these very, very critical hygiene protocols. Mm-hmm. So there was all these things that, were an accident waiting to happen, if you wish. Another thing too was, it's not only the people in long-term care that were having problems, it's the people that went home to be in isolation, in their own isolation. And not everybody has a very good home situation. Not everybody deals well with that kind of stress. And when people are stressed and not doing well at home, sometimes that can have repercussions in how well they can do the task at work. And of course, whether it's intentional or not, you may not be able to pay as much attention. You may be exhausted. Exhaustion, another risk factor. Right? So you have a lot of people that had to quarantine if they were in contact. You had others that actually got sick. So you had less of a pool of people to do the work. The ones that were doing the work are exhausted. When you're exhausted, you make mistakes. Do you want to make a mistake? Obviously not. But unfortunately, a mistake has a price, and the price is paid by the resident. So as we can see, there were so many risk factors that were just totally exacerbated by the COVID situation.
And the type of mistreatment that we heard more about was more, not violence, but was more about neglect. Can you talk a little bit about neglect?
Well, it's a little bit exactly that. So how does neglect take shape? So basically, in a care situation, and this is very common to the organization of services in residences and long-term care facility. You give a certain amount of time per person to do a task. For example, toileting and meals hygiene. If that person was semi-autonomous when they walked in and all of a sudden they're sick, what was supposed to take 20 minutes now takes 40. While that's happening, the other 20-minute log behind you is behind, and then you go behind, and then you go behind. What happens to the third, the fourth person? And if one takes 50 minutes instead of, so there is going to be neglect. You're not going to complete the task, but by the time you get there, the person's really not going to be in such great shape. And it's about that kind of neglect. Neglect is also when you do not know that you're supposed to be doing something a certain way, and therefore you do it wrong. So you neglect to follow proper procedure. And by not doing so, I'll give you an example, not doing and following proper protocol of hygiene. That neglect could cost the life of one of the residents. Did you do that on purpose? Not. So I think it's things like that will amount to situations that, of course, prejudice people in these facilities.
We also heard the fact that since caregivers could not come in long-term care facilities, they also did some of the tasks. So not only did some of the tasks take longer, but also some of them used to be done by family caregivers.
This is a very interesting topic that was put to the forefront. Number one, I think it's fantastic that family members and private caregivers, when possible, when you can afford to have them, get involved. There's nothing like having a child of yours or someone you love, take the time to feed you or help you versus a stranger. So anytime you can do that, it's good psychologically. And I think sometimes we undervalue the importance of the effective aspects that need to be felt for a person, especially when they're not doing well, when they're not feeling well. So it's normal that if a family member is visiting and is there, whether they take it upon themselves or not, they do a task. And therefore that task is now compensated for. That has allowed the people that work, the staff, to devote more time to others. And I think if that is not calculated as part of the running of the institution, when all of a sudden we pulled all these people out, we may have underestimated how much they were actually doing. And I think that it's something that needs to be looked at and needs to be calculated. And it's something that needs to be encouraged. No one's ever going to replace what a family member can do and should do, but it has to be looked at, you know, and documented and weighed. So if a caregiver can no longer come, or a situation happens like we just had, that we know where to put the energy. Mm-hmm. We know that Mr. X was always fed by his daughter. So if you just bring the plate and you leave it there, Mr. X is not going to eat it by himself.
Yeah, so there's an adjustment there too for the staff. And also, you're talking about the personal contact. So neglect is not just about eating, but it's also about interacting with family members, having people who love you. So more there's psychological aspects too.
You know, we're talking about psychological aspects. So I want to bring up one, before we get to neglect, I'm going to go back a little bit. People mean very well when they want to be a little bit more familiar with older adults. But sometimes that kind of reassurance or familiarity that you want to create leads to infantilism, right? When you infantilize someone. And then sometimes you're treating a person that's in their 80s and their 90s, and you're talking to them like they were 5 years old. My, don't we look cute today? I don't know. I don't know if it's such a great feeling to be considered cute at the age of 90. And you forget, and maybe it's because you see the care need. So sometimes that also is a form of neglect. It's a form of non-recognition of the adult behind the illness and the care. So it's these things, and of course, that's one of the issues in long-term care. Sometimes they're tolerated because they're done with good intentions. For the one who likes it, not a problem, but the majority of people do not like to be treated like children once they've gotten past that stage. So we have to be very careful about those things. Also, in terms of, you know, what is the most important thing for a person who's sick? It's reassurance. If your family member tells you that the staff is doing well, you believe them. If the staff tells you we're doing what we can, maybe you don't. So we need also that reassurance, and that's something that needs to be factored in. It has to absolutely be factored in when we're making future planning and we're trying to problem solve. That cannot be replaced by anybody else but the ones that love. And I think that maybe there's something to do about that, and we'll look at that in the solutions.
And also, we know from the work we do that mistreatment in long-term care is not a new issue. So can you explain to people how things were before COVID? So you told us how they became worse and why, but how were they before?
I think that there's always been issues and questions about ratio, staff to resident. I want to talk a little bit about the complexities of residences in particular and long-term care institutions. Number one, nobody goes because they want to. People go because they need it. You're talking about people that already go in at a time that they're very frail, and that they have degenerative illnesses, and they have very often a combination of illnesses. So they come in on a Wednesday, and on the Wednesday, their status is they can help themselves a little bit. The Thursday after, they have a mild stroke, and now they went from being able to do certain things for themselves to be able to do nothing for themselves. They're in that room, they can't move. They're in a facility that cannot answer to their needs because they weren't supposed to be at that level. And I think that's how a lot of things have started, where when family members could, they came in and they made the difference because they want them to stay. It's an environment, usually they like the environment. A lot of people are in the wrong level of care. And being in the wrong level of care puts a lot of strain on the people that provide the care, but a lot of strain on the families that see that they're not getting the care that they need. And these fluctuations happen very quickly, but it's very hard. As we all know, there's not enough care beds to move somebody from one level to another. You have to wait for that bed to be liberated. And so, you know, we mean well, but we're talking about a population that is extremely heavy duty and that's extremely fragile and changes very quickly. And therefore, what could have been appropriate and worked very well can change very rapidly and no longer function. And it, like I said, it's like a domino effect. If people are supposed to take X amount of time to take care of, and all of a sudden that changes, well, you know what? you have the backlog, and then it becomes like a bit of a circle. And those are the circles that people have been talking about for a very long time. There's not enough people. And already when there's not enough people, and all of a sudden people get sick, or because of their own fears do not come into work, well, then you have, you know, a terrible, terrible situation.
So a staff shortage. Mm-hmm.
Or staff that can meet a very rapidly changing need, and they're not ready for it, or they may not have the training for specific type of care. They expected to take care of people that were semi-autonomous, and now they're taking people that are fully non-autonomous, and therefore using different type of machinery, different techniques that you actually have to use for people who are dead weight, for example. You have to know how to move them. You have to know how to turn them. You need to be taught these things. It just doesn't happen. And those can lead to, of course, to situations of neglect or improper care.
So in long-term care facilities, you have the people that have very severe disabilities.
Well, I think that when you know they have the severe disabilities, you place them in the right level of care floor. What I'm saying is that those fluctuations mean there's always people waiting to get in the right care. In the meantime, they're in the wrong care floor. And there's people trying to catch up to do the care. And I think that's something that needs to be looked at too. You know, how quickly we can move people through, provide the right type of care where they are. And I'm sure it's extremely stressful. I always say that people who work in these environments, it's a calling. You have to really want and you have to really be able to do it. It's very difficult to see people that are in very difficult situations and that are suffering. And I always say also, we have this image sometimes, if you haven't worked with a lot of older people, of the warm and fuzzy, nice, elderly person. Well, elderly people are all like regular people. There's some very nice ones, and there's some ones that are really not very nice. And especially, if you add cognitive impairment or other neurological illnesses that cause disinhibition or aggression, they could be extremely dangerous people. And so the staff really, have to have an extreme amount of compassion and know how to deal with people that have very aggressive problems. Another point that I'm going to bring up that is very specific to residents in long-term care is resident-to-resident mistreatment. You have people that have, different problems that may make them react to each other, and that also you have to be careful and you have to account for, and you have to be able to change people and move them from one area to the other, so that people that don't get along well, that you can't control or you can't reason with them, you have to move them. So it's actually quite a juggling act when you're dealing in those situations. It's not an easy one, but nonetheless it's one that has to be done.
And now that people are somewhat more aware of mistreatment problems in long-term care facilities, which action should be prioritized now, according to you?
Okay, so I look at actions twofold. Mm-hmm. Number one, it's in terms of priority. If you already know the problem exists, go there and fix it. That one right now. And I'm talking about, it's nice we're talking about globally. Now we're talking about individuals. If Mr. X is in this situation and Mrs. Y, then go fix Mrs. X and Mrs. Y. Okay, so that's number one. And for this, I must tell you that all health and social service establishments, as of November 2018, had an obligation by law to have a policy to address mistreatment in all levels of care in their institutions. And these policies have been built and developed in order to support staff to A, recognize mistreatment and know what is a more effective way of managing it. So go back to these policies, consult them, look at the tools, look at the resources that they refer to. They are a guide on how to manage these situations. We know about long-term care. As a matter of fact, the law that came out in 2017 to counter the mistreatment against older adults and other adults in vulnerable situations specifically, was looking at people in long-term care facilities and people that are already under some type of legal representation. These people we know are vulnerable. These people we know need help, and we, if we're an institution, have assumed the responsibility for their care, and therefore there's an obligation to do so. When that's not done, there's an obligation to report. The ombudsman has been the dedicated person to report to. Reporting is not punishment. Reporting is fixing. Reporting is there's a problem here, and let's fix it. And I think that's a very key thing, which brings me to my second point when we're addressing a problem. What do we want to do to improve quality? Who do we need to put around that table to know what that we're doing right. And I think that approaches that have been known to work are collaborative approaches. They're approaches that, you know, put together the stakeholders. Which is the most important stakeholder? The residents themselves, the one that can actually, the ones that can contribute, put them at the table, put the care, you know, their caregivers, their family members, the people that work for them, the people that manage these institutions, the people that bring in even support from outside. The more people you put around the table, the more it is. The ombudsman, the users committees, these are the people that know what's going on. Remember, sometimes things aren't said to management, but they're said to other people. And we need to go and get that information to actually address certain issues. That's at one level. It's like looking at policies, looking at trainings, and making people more aware. And now we have to look at a little bit, like we were talking about at the beginning of this interview, is the risk factors. We know what the risk factors are. So let's go and let's diminish those risk factors for the future. Let's maximize the involvement of family members. Remember, they give that important emotional support. Remember, they are the advocates. They're the ones that'll be able to speak for those who cannot speak. Encourage reporting, right? So that's number one. Make sure your staff is trained for the growing needs or the changing needs of people that they're responsible for the care. If you have staff that you don't think is coping well, they're not going to be giving a good service. So we need to be careful about that. And therefore, you know, maybe not push people to work when they can't or they don't feel comfortable working in a certain environment. And then there's something that's been a lot on the table right now, but it's very important. Working conditions make a huge difference on service delivery. So if we have the proper working conditions, you know, that we stabilize people's jobs, we have the same people that maintain jobs, that they enjoy their work environment, well, the outcome will be a positive outcome for the people that receive care from them. So all these things are very important. Is it going to be easy? Absolutely not. But these are the factors that you need to put in your equation to see if we can do a better job, and always strive to do a better job.
So happy people make people happy.
Well, I think that, you know, it's no surprise. People that like their environment and like their teams are going to do a better job. I'll give you an example. In any team, you know, if you have teams that work very well and all of a sudden, you know, I feel under the weather today. Well, you're going to pick up the slack for me. On the other hand, you know, if I don't get along with you, well, you know, since she's having a bad day, too bad for her. But the slack in long-term care is the care of Mr. Jones, of Mrs. Smith. Mm-hmm. That's the difference. So you want to create these environments that people, you know, help each other and support each other and saying, you know, we're working as a team. And teamwork is really important. That's why certain institutions have a lot less problems than others. It's not just the number of staff, but how the staff get along and what are the conditions for the staff.
Okay. And so what do you want us to remember about mistreatment in long-term care facilities?
I think the key about mistreatment in long-term care facilities is that it's an environment that's a care environment, but it's also a social environment, a work environment, and living environment for people that are in very, very bad situations. And therefore, it's a very fragile environment. And if there's any place that we should really be careful, open our eyes, report what we have, and work together for solutions and not point fingers, but get something done, is that environment. Because, you know, like I said earlier, nobody goes into long-term care because they want to. They go because we have to. And we have to rebuild the trust that we can send our loved ones or go ourselves if we need it in the future and feel that we will receive the proper care.
Yeah, it's also about future generation of residents.
We need to rebuild that trust.
Yeah, because like right now, it's like nobody wants to go there. It's like people are scared of long-term care facilities right now.
So we need to recreate that. And I think we can. I think we can. You know, when people have to give up taking care of their loved ones at home, there's a big mourning process that go. And like I say, usually when you have a resident, if they do have a family member, it's their biggest asset. It's their biggest gift. It's the best resource that you have.
Yeah. So let caregivers in.
Absolutely.
Well, thank you very much, Sarita. So interesting and enjoyable.
Thank you, Mélanie.
And have a nice day.
Thank you.